Hi, my name is Gurpreet Dhaliwal. I'm a professor of medicine at the University of California, San Francisco, and a staff physician at the San Francisco VA, where I practice hospital medicine, emergency medicine, and outpatient medicine in the medical clinics. My academic interest is how doctors reason and how we improve our thinking, particularly in the task of diagnosis. Um, my session is about our collective diagnostic bias we've had during the COVID-19 pandemic and what we can do about it. The disproportionate impact of the COVID-19 epidemic on minority communities has been definitively documented, but there's really an untold story about the barriers that minority communities face obtaining a timely and accurate diagnosis. And you have to think about how important the diagnosis is for this condition compared to other diseases. So unlike most diagnoses, this one has immediate implications for how you protect yourself, how you protect your loved ones, and how you protect your own livelihood and income. If you think about it, this condition has potential to be very deadly. And the minute you know about it, you have to know how you increase your self-monitoring and have a low threshold to seek treatment and evaluation. This diagnosis also compels you to maintain distance from your loved ones in order to keep them safe. And it's an immediate thing you have to do. And then finally, this diagnosis has major implications for work. Many places now require that you have proof of a negative test in order to return to work. Um, and to have all of these opportunities and not be told, oh, maybe you have it or maybe you don't, you have to have access to testing in the first place. And that is a major issue. You know, we really don't think enough about diagnosis and quality improvement or social justice efforts. But as you can see in the slide here, they are the #1 cause of financial harm and patient harm among all the errors that we make in medicine. And when we think about diagnostic errors, oftentimes we're worried about putting the wrong label on a patient, but there's an even worse error, which is just not getting the chance to get diagnosed at all. Uh, Utibe Estienne, who is at Ethnic Disparities Research, has outlined an entire framework for how we have disparities, but I want to draw our attention to access to the testing process. You will see all sorts of problems with communication around testing, like complex language or non-English language, or using media that doesn't reach all populations. You know, not everybody watches CNN. Um, there's countless advice about ask your doctor about COVID testing. Well, that's fine unless you have limited access to testing or you can't get a doctor's order. Or as we're learning, most of the testing is actually concentrated in affluent areas and neighborhoods rather than ones that need it the most. And then there's just the pure issue of trust in the health system. Minority communities rightfully have distrust of the health system. There was a recent episode of the Nocturnist storytelling podcast where a patient who came to an obstetrics ward was concerned that the doctor's swab that they were inserting into the nose for testing risked transmitting their infection to her. And all that sounds odd to many people. If you knew the history of testing and experimentation on her community that extended up until the second part of the last century, it would sound completely logical. And so there are trust issues that we have to overcome if we are going to extend diagnosis to all community. And the sad part is we don't even know how well we're doing. If you look at this graph, you will take note that almost all states in this nation now are recording death by ethnic and racial group and morbidity or diagnosis positivity by racial and ethnic groups. But access to testing isn't being recorded at all, except for in 4 states out of 50. And our work isn't done here just getting people tests for COVID-19. Soon the next frontier is going to come in testing. So it's going to be things like who gets access to immunity passports that allow them to go to work or go to their place of worship. Who will get access to testing during flu season that helps us figure out if you have influenza or COVID. And then when we start using computers and algorithms, which we know have racial bias baked into them, how will that affect our diagnostic testing? Um, so in this session, we're going to really talk about what work we have to do in terms of desegregating testing across neighborhoods, how we're going to finance testing in our healthcare system, how we message to communities that it's safe, it's available, and it's important to get tested, and how we're going to improve our own scorecard and exactly how we're doing. And fundamentally, we're at the same juncture we're always at, where we have to decide, are we going to learn from all our past mistakes that we've made across bias, whether it relates to race or ethnicity or gender or income? Or are we just going to add COVID-19 to our long list of failures when we've tried to achieve equity and trust in diagnosis? My sincere hope is that that's not the case.